Ladies and gentlemen, thank you for standing by, and welcome to the USDA Health, IT, and Broadband Opportunities for Safety Net Providers webinar presented by HRSA. During the presentation, all participants will be in a listen-only mode. However, you may submit questions to the speakers at any time during the webinar in writing using the chat feature located on the left side of your screen. Questions will be addressed as time allows following the second presentation. As a reminder, today's webinar is being recorded. It is now 2 p.m. Eastern Standard Time on November 22nd, 2013. There will be two presentations following today's webinar. The first presentation will be given by Ms. Jessica Zupolo. The second presentation will be given by Ms. Vicki Norman and Mr. Efren Tradiko. In a moment, we'll be sending all attendees a link to the chat feature that they can click on to download copies of the slide presentation for today's webinar. Additionally, all registrants will receive an email following today's webinar that will include an email address where you can send requests for copies of the presentations. I would now like to turn the call over to Mr. Anthony Oliver from HRSA. Please go ahead, Mr. Oliver.
Thank you very much, Operator. Good afternoon, everyone. On behalf of the Health Resources and Services Administration, I'd like to welcome everyone to today's Health Information Technology and Quality webinar titled USDA Health IT and Broadband Opportunities for Safety Net Providers. Before we start today's presentation, I'd like to make you aware of the HRSA Health IT and Quality websites. These sites contain toolboxes, additional resources, and archived copies of previous webinars. An archived copy of today's presentation should be available for viewing within 2 to 3 weeks. An archived copy of September's webinar on telehealth for safety net providers is now available for viewing on the HRSA Health IT site. Today's participants should be aware of recently released ICD-10 and Electronic Health Record Incentive Program materials, which are available on the CMS website, in addition to other new Health IT and Quality funded projects and resources on the ARC website. Other Health IT related materials include Buoyancy's new Health IT dashboard, an update to a meaningful use dataset definition, and a new National Learning Consortium resource. Participants may wish to visit the listed web links for further information. I'd now like to turn the webinar over to Ms. Natasha Manzanero from the Office of Rural Health Policy, who will introduce today's presenters. Ms. Manzanero?
Thank you, Anthony. I would like to welcome all HRSA grantees and members of the Safety Net community to the HRSA Health IT and Quality monthly webinar. This month's webinar is entitled USDA Health IT and Broadband Opportunities for Safety Net Providers. Today's technical assistance webinar will provide an overview of how safety net providers can take advantage of USDA Health IT and Broadband programs. In order to meet the goal of increasing economic opportunity in rural America and the safety net population, the USDA finances new construction and upgrades to telecommunications infrastructure. Access to high-speed internet services through broadband networks and other quality telecommunication services increases educational opportunities, improved availability of health care, job creation, retention and growth of business, and other economic growth. Today, the USDA Rural Development Utilities Programs carries on this tradition, helping rural utilities expand and keep their technology up to date, helping establish new and vital services such as distance learning and telemedicine. Today's speakers will provide an overview of the USDA programs available to support telecommunications and broadband infrastructure development and improvement, as well as highlight examples of how their programs are currently being used to support safety net providers. Before I introduce this afternoon's presenters, I would like to read a disclaimer. HRSA would like to add that this webinar is intended to serve as a technical assistance resource based on the experience and expertise of independent consultants and HRSA grantees, and its contents are solely the responsibilities of the authors and do not necessarily represent the official views of HRSA. In addition, HRSA does not endorse any health IT vendors or software systems, including the health IT systems featured in this webinar. Now I'm pleased to introduce this afternoon's speakers. Jessica Zupolo has been the Deputy Administrator for the Rural Utilities Service at the U.S. Department of Agriculture since July 2009. Jessica helps oversee over $65 billion federal loan and grant portfolio that finances water, waste treatment systems, telecommunications and broadband networks, electricity utility, smart grid, and renewable energy infrastructure projects in rural areas throughout the U.S. Prior to the USDA, Jessica served for 6 years as an investment research analyst for telecommunications, media, and technology research for Medley Global Advisors. Prior to joining NGA, Jessica served for 5 years as a legislative director for the National Association of Regulatory Utility Commissioners and also worked on Capitol Hill for 7 years. Next, we have Vicki Norman, who is the director of Baptist Health EICU in Little Rock, Arkansas. Vicki is a 20-year critical care nurse and served as ICU staff nurse, house supervisor, unit supervisor, director of critical care, and currently as director of EICU Care Arkansas, which is Arkansas's only tele-ICU hub. The Baptist Health EICU Care maintains of a network of 20 hospitals in 2 states supporting 223 patients from the hub in Little Rock, Arkansas. Baptist Health is Arkansas's largest healthcare provider with 8 hospitals and 130-plus points of access across Arkansas. Next, we'll have Efren Trajico. Efren is a nurse and the program line manager for the Baptist Health EICU Care in Little Rock, Arkansas. He has 24 years of experience as a critical care registered nurse and develops and maintains the clinical outreach division of the EICU for Baptist Health, including planning, project implementation, supporting site activation, and providing post-activation support. I would like to thank HRSA grantees and the Safety Net community for participating in this event today. Now I would like to introduce our first presenter, Ms. Jessica Ziffulo.
Thank you so much, Natasha. It's a pleasure to be on today's webinar. I'm Jessica Zufolo, Deputy Administrator for the Rural Utility Service, which is an agency within the USDA Rural Development Mission Area. And it's truly a pleasure to have a chance to speak to all of the HHS HRSA grantees and the entire rural health community about the suite of programs that we offer at USDA Rural Development to support rural critical access hospitals and providers in rural communities that are struggling to provide affordable, high-quality care to rural consumers. It is really a terrific partnership that we have established with the Department of Health and Human Services in the last 2 years, and we continue to collaborate on ways in which we can reach all the communities across the United States that are trying to provide affordable, high-quality solutions through technology and infrastructure. Today I'm going to talk about the USDA Rural Development loan and grant programs that would be the most appropriate and the most useful to everybody on this call. Again, as Natasha mentioned, this is a webinar that we're really, really honored and pleased to be part of, and it's going to be, I believe, the beginning of multiple opportunities through webinars and other types of outreach that we will be doing across the rural health community. So consider today's discussion to be the beginning of several technical assistance training sessions that we're going to be providing to all of you. Today I'm going to talk about the RUS telecommunications and broadband loan programs. Then I'm going to talk about our distance learning telemedicine grant program and our Community Connect grant program. Then I'm going to talk about our Community Facilities Loan and Grant Program, otherwise known in the rural economic development community as CF. And then I will talk about the Rural Economic Development Loan and Grant Program, known to our rural communities as REDLEG. And then finally, I'll talk very, very briefly about the RD Business and Industry Loan Guarantee Program, known as BNI. And all of these programs are really a terrific toolbox for rural health providers to really learn about and understand how best they can be used to help cover such things as hardware and software costs, technology, as well as connectivity. USDA is committed to helping improve the economy and quality of life of rural America. That's our mission. We're very focused and have had a very extensive history in doing loan grant combination awards to support the economic development needs and the infrastructure needs of rural consumers, rural businesses, and rural anchor institutions. The Rural Development Mission Area was developed through the Farmers Home Administration, and in the 1980s the Rural Utility Service, formerly the Rural Electrification Administration, was merged into the Farmers Home Administration to become Rural Development. Our financial programs, as you can see on the slide, support not only electric and telecommunications connectivity and facilities and services, but also community facilities such as water and sewer systems, housing. We finance health clinics. We finance the construction of hospitals, schools, as well as emergency service facilities such as PSAPs and emergency critical care facilities. We also promote economic development by supporting loans to businesses and nonprofits. We have specific programs to support the establishment of cooperative business structures so that rural consumers can coordinate and organize to support the infrastructure needs of their areas, often in communities that have been overlooked or ignored by the anchor service providers in the region. The Rural Development Mission Area has close to $20 billion in loans, loan guarantees, and grants through these programs that we financed just in the last year. So we have a very proud and long and extensive history in supporting and providing specific and very targeted funding sources to meet the critical infrastructure needs and ultimately providing a safety net, so to speak, for rural consumers to ultimately attract risk capital and become sustainable economies. So I'm going to talk a little bit about the Rural Utility Service loan programs, which I think is just a good overview for what we do at RUS. And again, just to reiterate, the Rural Utility Service is an agency within the Rural Development Mission Area. And we have two other agencies, and much of the programs that I will be talking about today, with the exception of the RUS programs, are administered across the United States by our rural development offices and field offices. In the 1930s, as I mentioned, the Rural Electrification Administration, formerly the REA, was established to provide financing for rural electric co-ops and other entities to bring affordable electric service to rural communities. The REA was established, as many of you may know through your history books, primarily to provide services to communities across the United States that were not receiving electric service and were in many cases overlooked. So during the 1930s, the former President Roosevelt, recognized the need for a federal financing engine to support economic growth through infrastructure, and hence the REA was established. Then in 1949, the Congress realized how effective rural electric service was in transforming rural economies. So what they did was extended the rural electric program to provide telecommunication services to rural consumers and rural businesses and rural anchor institutions. So we have been providing lending to finance rural telecommunications, voice, and later on broadband for well over 60 years. Funding in the last, since 1949 and up until 1995 was provided for basic voice to ensure that rural residents were not overlooked and had essential utility service. And then in 1995, the agency decided that it was important to bring rural America into the digital age. So our agency was the first, really, in the federal government to ensure that all telecommunications networks be broadband capable. And this was before the 1996 Telecommunications Act, which really revamped the country's statutes to move into this direction. But at RUS, we feel that rural America is really where innovation starts. And so we wanted to really meet the the insatiable appetite among rural consumers for next generation technology. And at RUS, we feel that we have well over a 77-year history of bringing technology to rural America, starting with electric service. So broadband and communications service, fiber optic network capacity, and technology is the next frontier of our mission at RUS that started in the 1930s with electric service. So the basics of the program are as follows. Since 1949, the RUS Telecommunications Infrastructure Loan Program, again, that's an extension of the electric program, has funded close to $22 billion in projects for new and improved telecommunications infrastructure for communities of a population of 5,000 or less. The program receives and is eligible for applications all year round, so we're always open for business at RUS. The interest rates are just so really remarkable in the types of projects and the kinds of mortgage instruments that we offer for infrastructure. Because we are a federal lender and because of the very careful and rigorous underwriting that we do, the interest rate environment and the interest rates that we can offer are at Treasury rate financing. So depending on which of course depends on the loan maturity at the time of each advance. But the rates are tied to the Treasury rate of interest, which is extraordinarily and historically low today. So we can do 20 and 30-year construction notes for broadband infrastructure at close to 3%, which is better than anywhere else you can possibly get in the commercial markets or anywhere. So we are open for business and always looking to finance broadband across rural America. The term of the note is based on the useful life of the assets. So if you're building a fiber optic network to a hospital or to a school or to a rural health clinic, typically a fiber-based asset has an amortization rate of substantially longer term than maybe a wireless network, which is a much shorter amortization rate, given the fact that the cost of electronics on a wireless network is often upgraded quicker. Again, all infrastructure we finance must be broadband capable. So I want to just stress this. This is a very, really important program that we're very proud of, and we encourage everybody and anyone to be knowledgeable about this program, and to encourage consumers and anybody in your community to come and talk to us about loan financing for a broadband network. Now I will talk about the Farm Bill Broadband Loan Program. This was a program that was established in the 2002 Farm Bill and then reauthorized in the 2008 Farm Bill. We provide low-interest loans, again, like the infrastructure program, to fund the cost of construction, improvement, and upgrades, as well as acquisition of facilities and equipment, to provide broadband service to communities on a technology-neutral basis. We're a technology-neutral lender, so we support all platforms into rural communities as long as it's financially and operationally sustainable. The goal of the program is to ensure that rural consumers benefit from the same quality and scope of services that are available in urbanized and suburban communities. The second bullet really encapsulates the underwriting principle that we've adopted at RUS, which is essentially the tenets of the Universal Service requirements in the 1996 Telecommunications Act. So RUS provides loan financing to ensure that, again, rural consumers receive the same level of services at the same pricing as those in urbanized areas. So the Farm Bill program, just to recap, is really a program for newer entrants to communities. It's a program that is for what we call in the telecommunications space competitive local exchange companies, so satellite, wireless, cable, but traditional telecommunications providers are also eligible as well. So again, these are just some tools that we have at RUS to ensure that broadband access is available to communities that are just limited due to density and cost, which is really the focus of everything we do at Rural Development. Now I'm going to really just talk quite briefly about our Recovery Act investments, which we are very proud of and often remind audiences, particularly rural health audiences, of the scope of the investments that we've made across the United States to provide high-quality, affordable broadband services to rural anchor institutions and consumers. We did about $3.2 billion in loan grant combination awards for close to 257 infrastructure projects. We're extremely pleased with the rapid progress that all of our grantees and borrowers and awardees under the Recovery Act have made to build out broadband infrastructure to their communities. $2.6 billion of the projects have already been completed, and we've got close to $2 billion funds have been advanced thus far. So we're very rapidly moving forward in completing the Recovery Act investments. And the one piece I want to remind the audience is all of the investments that we make at RUS require that the grantee or borrower, and in particular the borrowers or the customers for the last three programs that I've mentioned, including Recovery Act awards, must build out to the entire service area. So we have already built into our programs a anti-redlining type of requirement, so they must provide service to the anchor institutions in that community as well as residential customers. And this is a graph that just shows you the breakdown of the types of projects that we did under the Recovery Act. The bulk of the projects were wireline, facilities-based broadband projects to the premise. That includes both residential and anchor institutions. And then about 51 of those projects were wireless, and then 33 were wireline, wireless combination awards. Now I'm going to switch to the Distance Learning Telemedicine Grant Program, which I think is of particular interest to all of you. And this is a program that we're just so excited about because this is one of the only grant programs in the federal government that provides specific financing for technology and equipment to facilitate advanced health care delivery to the most rural and remote portions of this country, including tribal communities, which are often the most underserved. The program's eligibility are communities of a population of 20,000 or less. The entity must deliver or propose to deliver distance learning or telehealth or telemedicine services for the term of the grant, which is typically 2 years. The purposes must meet the grant definition of either distance learning or telemedicine with a focus on sustainability. So sustainability is really a key focus of the work we do at RUS because we want to make sure that the grant funds that the federal government disperses is really used carefully, wisely, and has an after effect in the community that ensures that consumers can receive that service from the grant that we have provided well beyond the term of the grant. The grant cannot be funded for planning or research projects or short-term demonstration projects. It also can't go to individual entities. It can only go to for-profit or non-profit entities for the provision of telehealth. The minimum grant award is $50,000 and the maximum grant is $500,000. There's a 15% matching contribution requirement in order to ensure that the awardee has equity into the project. This is a competitive nationwide grant program, so the notice of funds availability is typically issued in the Federal Register, usually around springtime, and we announce our awards usually at the end of the fiscal year. Due to the disjointed nature of the fiscal year this year, or in 13 rather, we have not announced the distance learning telemedicine grant awardees in the FY13 fiscal year yet. The Secretary of Agriculture is slated to make those announcements sometime at the beginning of December, so please keep your eyes open for that, and we will also make sure that our colleagues at HRSA have all of the award announcement information that can be distributed to all of you as well. Some of the uses under the DLT program include things that we can cover such as computer hardware and software costs, computer network components, terminal equipment. We can cover the cost of data terminal equipment, OEM or OEM authorized warranties on eligible equipment up to 3 years, and inside wiring. So it's quite broad. Before I talk about our Community Connect grant program, which is another grant program we offer at the Rural Utility Service, one more comment to mention about distance learning telemedicine. It is really one of the most popular programs in the federal government. Unfortunately, we have pretty limited funds for DLT. As I said, it's a nationwide competitive grant program, so we are heavily oversubscribed in grant applications seeking federal grant awards pretty much every year since the inception of the program in 1993. We do everything we possibly can to really examine the requests and the needs for financing in every rural area. And we do everything possible to finance every possible project, but given the fact that it's a small program, in FY13 we'll have about $18 million in projects that will be announced sometime at the beginning of December. But next year, which is this fiscal year, FY14, we may have a little bit more to disperse in the total amount, but it's a competitive grant program, so we always encourage grantees to take some time to look at the RUS website and really learn about how best to apply for a DLT program. We have a list of all the DLT previous awards over the last years broken down by state, so they really do give you a very good snapshot as to the type of projects that we funded, to give all of you going forward some feel for the types of grantees that have risen to the top on the scoring. So now I'll talk a little bit about the Community Connect grant program, which is a program that provides grants to the most rural and remote portions of the United States. The eligibility for the Community Connect grant program are communities of 20,000 or less, and it provides grants to poor, rural, and unserved communities where broadband service does not exist or is really unlikely or has not been available and has had a track record of facing difficulty in attracting a broadband service provider in that area. Alaska, Hawaii, and the lower 48 throughout the United States and the territories, the grants has done remarkable things to provide broadband service to enable educational, business development, public health, public safety opportunities to rural residents living in the most extremely remote, underserved communities. Typically under Community Connect as well as DLT, we have a fair number of tribal awardees that have just tremendously impressive stories about how through these grants they have transformed their economies. Now I will talk about the Community Facilities Loan Program. Now, this is a program that is administered not by my agency, but by the Rural Development Mission Area. And this program, like the programs that I'll be talking about for the remainder, are administered by the Rural Development State Offices and Field Offices. And I will give you an overview of how those offices work and how you can access them, which is a key to all of you in tapping the program dollars we have available. So the Community Facilities Program was established by Congress to provide access to capital for critical infrastructure, specifically for municipalities and for communities, and to facilitate community-based investment. Community facilities finances things like rural hospitals and clinics. So the construction of a health facility, the inside wiring of a health facility, the technology that's purchased for that health facility. It can also cover the cost for fire, rescue, EMT, and public safety facilities and equipment. rural education and rural libraries, construction and equipment, public and municipal services such as clean water and sewer projects. In 2013, we did $70 million in direct loans and $10 million in grants across the United States. And this program, like the two I've just referenced, are eligible for rural areas and towns of a population of 20,000 or less. Applicants must be nonprofits, governments, or tribal entities. So primarily, money under community facilities can only be eligible among those who are municipal, government, or nonprofits. So this is a success story we like to just highlight. This was a really neat project in Elgin, Minnesota, where they financed a community facilities loan to do a teledentistry project. We've invested since from 2009 to 2012 about 7,800 projects for critical community facilities serving over 30 million rural residents. So this gives you a sense of the scope of the work we do in community facilities. And again, this is a program that's administered across the United States in our rural development state and area offices. Another success story is Stevens Memorial Hospital in Breckenridge, Texas. The project was an electronic medical records system, and the hospital, their current mainframe system was really old and just did not meet the regs under the Affordable Care Act or Medicare and Medicaid services or CMS service requirements for electronic medical records. So the hospital server is over 9 years old. So now under the CF loan and grant awards, we were able to do $460,000 for upgrading their hardware to accommodate their electronic health needs. So we're really just thrilled to do projects like this, and we do it across the United States. Now I'll talk very briefly about the Rural Economic Development Loan and Grant Program. And again, like the previous program, Community Facilities, this is administered by our state offices. This is a program that's both loan and grants, and it's a program that is so important for the rural health communities across the United States because this facilitates a partnership through the rural cooperative, both electric and telecommunications cooperatives that are eligible to basically be a secondary lender in their markets to facilitate things like any type of economic development project. So it's a really just a neat program that we always try to highlight for rural health audiences to be aware of, and to reach out to your local rural electric cooperative, both electric and telecommunications cooperative, to talk to them about the Red Light program and see how perhaps a project can be established to finance the cost of health upgrades in any way, shape, or form in your area. So the loan program provides loans to utilities, like I said, our cooperative systems that are eligible RUS borrowers. Then they, in turn, pass through the financing to support local projects, to create or retain jobs in rural communities. The recipient, so the cooperative repays, or actually the hospital pays, or the health provider pays repays the loan back to the utility at a 0% interest rate. So it's really a remarkable program. The grant piece is very small, but it's available as well. But again, a 0% loan for 10 years we usually see is quite in high demand and has a huge need out in rural communities that can't access capital. So the loan maximum amount is $1 million, and the minimum is $10,000 for projects. Payments may be deferred up to 2 years, and there's a 20% equity match required from the utility intermediary. And then the grant program is $300,000, and the minimum is $10,000. So a really neat Red Lake success story was in Algona, Iowa, where we did a $360,000 to install integrated technology as an electronic health record system, installed in new rooms through an expanded computer network, and this was through the Corn Belt Power Co-op. So they were a recipient of the Red Leg loan program through USDA and then relent the money back to the Kossuth Regional Health Center to do to help them facilitate an upgrade of their EHR. Really quickly, the Rural Business and Cooperative Program Services is a sister agency of the RUS, and the bulk of their programs, again, are administered by our state directors and state rural development specialists across the United States. They work hand in hand with private sector and community-based organizations to essentially provide at-risk capital to rural communities to build and support business development. Those eligible are individuals, which is very unique. The other programs I mentioned are not. Corporations, cooperative, public and private entities, tribes, and nonprofits. So this is a picture of a section of the Rural Development webpage that I always try to highlight for folks. Very, very important for all of you to take the web address and put it in your favorites, because this is the web page that you're going to all go to click on the state that you're from to learn about how best to access USDA Rural Development state and field offices in your area. And this web page will show you if you're from Texas, Wyoming, Montana, California, the Northeast, Southeast, or the Appalachian region. This will show you how to actually access the specialists on the ground that will work with you very, very closely to access the programs that I just discussed. People that you all need to get to know. This is a very important list, and I want to emphasize it strongly and make sure that you all have a chance to follow through. Our state directors of USDA Rural Development. On the previous slide, I showed you how to reach them. These are people that are hired to basically help finance infrastructure projects and disperse the financing that I just mentioned in all the programs that I just discussed. We have 47 state offices and field staff ready to assist at any time to help your infrastructure needs and your health IT, hardware and software challenges if you provide service or trying to provide service in a rural area. Another set of folks you need to get to know are our field representatives. RUS have a group of people that we work that report up to the national office that are our eyes and the ears of the agency and the department in every rural community across the United States. And our field representatives that work for the RUS telecommunications program, you can get a list of their names and their contact phone number and email addresses. And these are the folks that you need to speak with directly to talk about the telecommunications programs. You can call them and say, hey, you know, we have kind of not so good service in our area, and what do you think is happening? And they are business and industry and engineering specialists that work directly with our borrowers, all of our grantees. They know every project that we financed. They know everything going on with broadband access in your area, so we want you to make sure you talk to them. And of course, our borrowers and grantees. These are the people that will tell you exactly how it works, and thank goodness we have one of them on the call today. So we're very pleased to have our colleagues at Baptist Health on the bridge. And then stakeholders, rural electric and telecommunications, cooperatives, and independents. These are the folks that are the key engines for the Red Leg program I spoke about. Rural water systems, Farm Bureau leaders, rural health and education organizations, and rural economic development organizations like the National Rural Economic Development Association, the Appalachian Regional Commission, the Denali Commission, and the Delta Regional Authority. These are folks that we work collaboratively literally every single day to come up with ways in which we can get to yes in getting things funded. Very quickly, cooperative extension. This is a very, very important engine within USDA that's part and parcel and financed through the land grant college and university system. You can go to the website and access all information on where cooperative extension services and cooperative extension centers are, where they exist, by going to www.nifa.usda.gov/extension. It's a nationwide non-credit educational network, and it is really one of the most extensive and oldest rural economic development engines in the United States that's part of USDA, and they have money and they have program dollars and infrastructure of human capital ready and able to assist every rural community meet their financial needs. Very quickly, NIFA supported, the 4-H programs are also financed and supported through the National Institute of Food and Agriculture and touch close to 6 million children every year to promote things like STEM, to promote educational access, GIS mapping, and technology access into rural communities. 4-H is also a really terrific and important organization that the rural health community should be working closely with, because it's literally in every rural county in America, and it's part and parcel of the USDA network. Here's my contact information, and I encourage any of you to reach out to me with questions. And I want to leave all of you with just no project is impossible. We're already focused on helping to, again, get to yes, to finance the most difficult areas that are the highest cost and the most remote to serve. And this is a poster that we put together on the 60th anniversary of the telecommunications program. Clearly, our job in rural America is not done. We're scratching the surface. We still have so much more to go, but we feel that partnerships like this and collaborating with all of you is really how we're going to get there in helping transform rural communities into engines for growth and technology evolution. So with that, I will turn it over to my colleagues at Baptist Health.
Thank you, Ms. Zufolo. I would now like to introduce our next presenters, Ms. Vicki Norman and Mr. Efren Traico.
Good afternoon. Thank you for the introduction. I'm here today to tell you about how Baptist Health in Little Rock, Arkansas, as a recipient of the USDA DLT grants, was able to build a network of tele-ICU support for safety net hospitals across Arkansas. What I'll talk about today, I'll start by describing what tele-ICU, more commonly known by the name of the leading vendor, EICU, is. I'll briefly discuss the magnitude of challenges of meeting the healthcare needs of the people of Arkansas. I'll talk about why tele-ICU is a useful tool to help leverage our scarce resources, extend services to rural hospitals for their population served. I will tell about our story, how we came to the USDA. We were a couple of ICU nurses with an idea about what we could do to help, and I'll mention some things we had to overcome along the path that may be useful for those that are going to pursue a DLT grant. I'll talk about where we are with the project, how we're making a difference, and what the future holds for us going forward. A little bit about what EICU is. It's a critical care telemedicine. It's a critical care telemedicine telenursing program, clinical decision support powered by smart software, and it has what we call fuzzy logic that's able to tailor smart alerts and Sentry alerts based upon the patient's physiologic status and considering things like comorbidities and age. It's a data and clinical integration portal. We pull in all pieces of the patient's medical record, their lab results, medications, vital signs. We have a Sentry and alert system that can direct our caregivers where patients may be getting worse or in some cases getting better, and that allows us to wean some therapies and have some good outcomes with decreased length of stay. Best practice reporting solution, we're able to track how patients are doing. We're able to track through the system our participation in the patient's progress, and did we meet all of our quality metrics, and use it as a benchmarking tool to see how healthcare in Arkansas measures up on a national platform. Rural Arkansas. Some of you may know Arkansas is a widely diverse state geographically, from the Ozark Mountains to the Mississippi Delta. Economically, we're very diverse, from the international headquarters of the world's largest retailer to some of the most impoverished area in the United States and the underserved Delta farmlands. widely diverse levels of education, unemployment rates, and access to health care and services. Even in a geographically small state, the challenges that people in rural Arkansas face accessing health care specialists can be daunting. Currently, all counties in the state of Arkansas are considered medically underserved except 2. Currently, there are no critical care specialists practicing in rural Arkansas. Small rural hospitals have been largely unsuccessful attracting, retaining medical specialists for low population communities. There simply isn't the number of patients needed to support a practice dedicated in small townships and communities. Arkansas is a state particularly challenged because of the immense healthcare needs of our population. Arkansas sits smack in the middle of the stroke belt, the heart attack belt, and 30 to 50% of our people are obese and or suffering from chronic disease related to unhealthy lifestyle and habits. The challenge for healthcare providers to be able to meet the health needs of their local populations is daunting. Arkansas ranks close to the bottom in overall health status for its people. Tele-ICU provides rural safety net hospitals access to services that they could previously not provide to their populations. Knowing that rural hospitals are often the largest employers in communities, it's important that they be supported to continue the economic health and growth of their communities. High rates of poverty and high numbers of uninsured contribute to the challenges local hospitals in rural Arkansas face as they try to improve the health of the people in their communities. Since tele-ICU generates no charge to the patient, it's particularly appealing to rural hospitals as a service they can offer to this vulnerable group of Arkansans. Research over the last 20 years has clearly demonstrated that when people are cared for by a critical care physician leading a multidisciplinary team, that outcomes for patients are better when they experience critical illness. Recent statistics from the Society of Critical Care Medicine recognize a nationwide shortage of critical care specialists, referred to as intensivists. For every patient who experiences critical illness in the United States to be cared for by an intensivist, it would take 50,000 critical care doctors to meet the need. In the most recent published account by the Society of Critical Care Medicine, the estimate is that there are currently 6,000 critical care doctors in the United States. Intensive care medicine requires frequent bedside assessment and continuous management of patients. By using tele-ICU technology, the Baptist Health EICU is able to provide this continuous level of vigilance and patient care management to a population spread all over Arkansas at a fraction of the cost and manpower needed to provide that level of service locally in rural hospitals. One EICU physician can manage the care of over 100 patients at the same time, regardless of geography and distance. In critical illness, immediate access to specialists and the delivery of timely care saves lives. It prevents morbidity and improves outcomes. Tele-ICU allows intensivists to be present virtually at the patient's bedside in a matter of minutes at the touch of a button. Tele-ICU helps hospitals previously unable to offer critical care services to extend to their communities evidence-based care and standardized best practice previously available to their patients only upon costly and dangerous transfer. Transferring the patient hundreds of miles via ground ambulance or helicopter places them at increased risk for injury or death when they're critically ill. Since one of the first steps of addressing population health care needs is planning and coordinating care for people, by supporting local hospitals with tele-ICU service, hospitals are able to care for patients where they live. One of the services offered with a tele-ICU is the availability to do real-time, on-demand critical care consults with an intensive care physician. Technology and software are powerful tools in the hands of an intensivist. EICU doctors are able to support real-time, round-the-clock clinical decision support for bedside physicians and nurses as they manage multiply complex patients. EICU technology is the vehicle for both the bedside and the hub teams to collaborate, work together to provide care to the critically ill. Intensivists are able to see and assess patients, access their medical records, and have video and audio communication real-time with bedside teams, patients, and their families, allowing for continuous ICU patient management. Intensivists are available 24 hours, 7 days a week at the touch of a button to intervene in any emergency situation where our physicians and nurses can direct patient care and support bedside teams. One of the most important things that a tele-ICU can provide is the vigilance for compliance with best practice and evidence-based medicine. Some of the things the Baptist Health EICU care assesses for in every patient every day are quality metrics like progressive ventilator weaning, sedation and pain management, delirium management, formerly referred to as ICU psychosis, and other quality measures like prevention of complications by making sure patient risk is proactively managed. Nurses and doctors in the EICU round continuously on every patient every day to make sure there are no gaps in quality and that no need, no matter how small it may seem, goes unmet. This constant attention to detail and micromanagement of patients has shown decreases in mortality by up to 30% and decreases in complications as well as length of stay and costs. Nurses in the EICU are able to provide a safety network for bedside nurses, including mentoring new graduate nurses, helping local nurses with staff development, and meeting educational needs. In the Baptist Health EICU, the average level of experience in critical care is more than 20 years. Many of these nurses served as charge nurses at the bedside, were preceptors of new nurses, and educators for their intensive care units. But nursing is a highly physical occupation in the intensive care unit, and 1 out of 5 nurses will become, at some point in their career, physically unable to work at the bedside. These same nurses have a wealth of knowledge and experience. It was important for us to find a way to share this valuable resource with our patients and our staff. Being able to work in the tele-ICU has allowed these nurses to continue their careers. Some of the things an EICU RN does is provide an extra pair of eyes to watch over the patient. Collaboratively problem solve with bedside nurses, gather information including researching unusual diagnoses, medications, or procedures. EICU nurses can watch patients for the bedside team while they're busy with other patients, which has reduced falls, complications, allowed nurses not to be hurried, and to take the time that they need with other patients, knowing that their patients are being cared for and watched over. This service has shown a decrease in nurse turnover in the ICU as well. The role of the ICU RN is only limited by the creativity of the bedside teams. One of the most important supports that EICU has been able to provide, in addition to surveillance, is documentation assistance where the EICU nurse can take notes during crisis so the bedside teams can focus on care and not documentation of that care. The Baptist Health EICU partners with Aurora, which is our organ procurement organization, to refer potential and actual organ donor patients, thus allowing bedside teams to spend the time they need offering emotional support and their presence to families of dying patients. Knowing that tele-ICU service would be a great benefit to rural hospitals was simply not enough to get the service started. Technology of this kind is very expensive, and with limited resources, it was undoable without the support financially of a USDA DLT grant. A federal grant was a daunting challenge for 2 novice nurse grant writers, but after 1 unsuccessful attempt to receive a grant, Baptist Health received 2 grants totaling $605,000 and were able to extend tele-ICU service to rural hospitals in Arkansas, placing a special emphasis on the extremely impoverished and underserved Delta region. With the help of the USDA, we were able to purchase 2 mobile carts for each of these rural hospitals, provide the software, cable internally ports for the carts, install the equipment, and train the local caregivers and technology staff. Some unexpected challenges that we faced in this project is something everyone faced, which was the economic crisis beginning in 2008. There were some shared costs that local hospitals must cover for us to be able to provide the service. With everyone's resources very stretched, the project had to be remarketed. The hospital's recommitment had to be achieved. Hospitals were faced with the necessity of choosing which services, solution, and technology they could provide for their local communities. In Arkansas, hospital executives have a turnover rate between 30 and 50% every year. So early engagement by executives meant for us that the entire process had to be remarketed and repeated. With scarce resources and with this being a little-known technology at the time, these hospital CEOs needed to be convinced that they were good stewards with their limited dollars in doing this project. Middle-mile broadband costs proved to be a significant challenge and oftentimes were equal to or even exceeded the net bottom line that hospitals had at year-end. Because of our commitment to the people of Arkansas, we were able to heavily subsidize these costs as part of our mission. As we moved forward, we were able to transition our hospitals from private pay broadband, costing up to $4,000 a month for hospitals, to the Arkansas eLink program, which is a $102 million grant to the state of Arkansas managed by the University of Arkansas for Medical Sciences. And then we were able to reduce their broadband cost to zero. Some of the successes that we've been able to achieve are reducing transfers for patients from rural hospitals to urban tertiary care centers. This reduces cost and risk to patients and allows patients to receive care where they live. It was important for our rural hospital partners to be able to serve their local populations with comprehensive and advanced care. This extension of the service has enhanced the confidence of people in their local communities in their hospital and has decreased the thought that to receive advanced critical care services, they needed to have their loved ones transferred to a tertiary care center. It helps them feel safe, cared about, and confident in the local teams. Physician satisfaction has been improved in these rural hospitals where workload is more reasonably distributed between the bedside and remote teams. Physicians who previously saw patients all day in their clinics and had to run back and forth to the hospital for critically ill patients, be called all night, and return the next day exhausted to repeat are now less subject to burnout and are more likely to be retained and have longer careers in smaller hospitals. Sometimes local hospitals were able to recruit just one physician, and there was no way they could support sick patients 24 hours a day, 7 days a week, so patients got transferred or physicians left. It's our hope that we will continue to offer this support and local hospitals will be able to use this service as a recruiting tool for new physicians who are seeking work-life balance. The future of tele-ICU is a bright one, with the ability for us to transition our USDA DLT grant recipient hospitals to free or low-cost broadband by partnering with Arkansas eLink. We believe in the sustainability of our program. An important part of what we do is to build trusting, collaborative partnerships with rural hospitals. Tele-ICU was the first step. It's our intention to share resources going forward based on specific needs of local hospitals to develop other service lines and tools for population health management. Some of the programs we are developing with our partners include comprehensive management for severe sepsis and septic shock, and therapeutic-induced hypothermia for post-cardiac arrest patients, as well as support for other vulnerable populations such as prematurely born babies, the elderly, hospice and palliative care support, high-risk obstetrics, e-pharmacy, and other specialist physician consults. Education and training of both patients and providers is a service shared by our tele-ICU. We're able to connect patients and providers real-time with caregivers and educators to meet their needs. Always a threat to our program is that there is currently no reimbursement model for tele-ICU care. Going forward, we're keeping meticulous records of patient care improvements, costs associated with the program, and operational organization to be able to share and convince payers, both governmental and private, of the value of the service in order to develop a sustainable reimbursement model that seems fair to everyone and improves the health of populations and access to care for the people of Arkansas. I appreciate so much. Thank you for the opportunity to tell our story. We're very grateful for this opportunity to share our experiences and grateful to the USDA for helping us better serve our people in Arkansas and their health care needs. Our contact information is here, and we welcome your questions. We encourage you not to be intimidated by the complexity of the federal grant process. Be creative, tell your story, and access this very valuable resource that we know will make a difference. Thank you, and I now turn you over to our host.
Thank you so much, Ms. Norman. Now, Ms. Natasha Manzanero would like to share some additional federal broadband and telemedicine resources. Please go ahead, Ms. Manzanero.
Thanks so much, Ms. Suckman. I would sincerely, from HRSA's Office of Rural Health Policy, like to thank the USDA and Baptist Healthcare for their presentations today. This has been a tremendous effort between the collaboration of USDA and our federal partnership, and would really I'm really pleased with this opportunity to have them present to you today. Here on this slide, you'll see a few federal broadband and telemedicine resources. Here you have the USDA website, You have the HRSA website for telehealth, and also the Federal Communications Commission website for broadband opportunities as well. I would like to turn the call back over to Ms. Suchman. Please go ahead, Ms. Suchman.
Thank you. We will now begin the question and answer session. I'm going to go through some of the questions that were received on the web chat. The first question I'm going to direct to Ms. Zufolo. Can the grants you spoke of be used for interfaces needed for ICD-10 or upgrades of electronic health record systems?
Hi, this is Jessica. Thanks for the question. The Distance Learning Telemedicine Grant Program, I'm not familiar with ICD-10, although I know it's very important to everybody on the call. But we can finance, as I said on my earlier slide, all equipment that is needed to facilitate telehealth. So if that involves specific expenditures for any type of technology to enable that health delivery system to be available in a rural area, then it is eligible under the DLT program. Community facilities is a loan grant combination as well mechanism, and it too can finance the cost of equipment. The main thrust of the community facilities program is primarily for facilities, but it can also cover the cost of inside wiring. So to the extent that you have a hospital or a health clinic that is upgrading or doing some capital construction or expansions of the facility, and you include inside wiring, and part of that inside wiring includes technology upgrades, then yes. However, I will caveat my comments by saying that I strongly encourage the questioner to, depending on where they are located, to reach out to the USDA Rural Development State Office and ask specifically how the community facilities program can be used for that purpose, and they can walk you through those details based on your unique circumstance.
Thank you. I'll do another question for you, Ms. Zufolo. Would grants be available to U.S. territories? And can you speak to technical assistance resource that might be available for drafting applications, if any exist?
Sure. Thank you for the question. So our programs are nationwide. That also includes U.S. territories. So if you are in the Western Pacific, I encourage you to reach out to the USDA Rural Development State Office in Honolulu. They also have offices in Guam, and I believe in America and Samoa. So reach out to them because they can talk to you specifically about how USDA Rural Development programs work in the Western Pacific. In the USVI, that office our work there is managed out of our Florida State Office. Richard Maychek, M-A-E-C-H-E-K, is the state director, and you can go back to the slide I showed you with the map of the United States and click on Florida, and all the USVI contact information can be found there. Because the grant programs are competitive, we don't provide technical assistance because we are just prohibited from doing so. With that said, we have a number of tools that we can help you with and make available and send you that provide guides and specific information on how the applications must be filled out properly and correctly. We do webinars, which we can do for a particular state if you wish, on the grant programs and really specific application guide information when the notice of funds availability has been announced and released for the FY14 fiscal year. But again, we cannot provide specific technical assistance on how to actually fill out your application and apply.
Thanks. And actually, since you mentioned the 2014 grants, is there an anticipated release date for those?
Well, we don't quite have our 2014 budget allocation yet by Congress, so we don't have any information to make available on that. However, usually our grant awards, our grant NOFAs are published in the Federal Register sometime in the springtime. And then that opens up the application window, usually at 60-day windows for applications to be submitted into USDA. And then from there we spend a good several months reviewing each and every application to determine eligibility and feasibility and the specifics of each application based on the scoring criteria. So I don't have that information right now.
Okay, thank you. The next question I would like to, was somebody else? Oh, sorry about that. The next question I'm going to direct.
I'm sorry to interrupt. I had one more thing I wanted to mention, and that is if you have specific questions, you can also direct them to me, and you can use the contact information I have at the end of my slide presentation, and we can always provide you with more tailored information based on your question. But for the general good of the order, for all the participants, just wanted to give you guys the basic information on how these programs are contoured. But specific informations are always welcome, and we encourage you to submit them.
Thank you. The next question I want to direct to Ms. Norman. It's on the definition of rural community as you were speaking. Is rural community in reference to a town that the organization is located in, a county, or a particular service area that an organization serves?
Some of the rules for the DLT program is that they have to be population centers of less than 20,000 or they're considered urban. So the requirements were population less than 20,000, and for us, we went through and looked at what were some of our most medically underserved areas, and we started where the need was first, and then we matched those that had high levels of need with the qualifications for the grant, and then that's how we worked sort of backwards, because we certainly had way more than 9 hospitals that we could have provided this service to, but we wanted to start with who needed it most. But anyone less than 20,000 qualify. And for our program, the hub is located in Little Rock, which is certainly considered urban. But for the hub purposes, the population was not a consideration. It's where the in-service is delivered. If that sort of answers the question. If not, please email me and I'll try to be more specific.
Thank you.
And this is Jessica from USDA Rural Utility Service. I appreciate my colleagues at Baptist Health for that answer. To reiterate, we can finance communities, as I said in my slide presentation, of populations of a community of 20,000 or less, as noted. So be mindful of the population thresholds of the communities in which you are seeking financing. For the loan program dollars that I mentioned regarding the RUS infrastructure telecommunications loan program and the broadband loan programs, the eligibility pertains to the entire funded service area.
Thank you. Actually, while you're speaking, I'll direct the next question to you. Is the Indian Health Service eligible to apply for grants in areas servicing rural populations, federal or tribal hospitals or clinics?
We do not provide financing to other federal entities. We only provide financing to cooperative, tribal entities, for-profit institutions, community-based entities, states, tribal, or local governments. We do not provide financing to other federal entities.
All right, thank you. I think the final question was someone just wanted some clarification on how broadband was defined for your purposes.
Sure. We establish broadband service at the speeds and the requirements set forth by the Federal Communications Commission. So the minimum broadband speeds that are established by the FCC are those that are adopted under the RUS programs. The Community Connect grant program for broadband service in communities with no broadband, we have purposefully in the Notice of Funds Availabilities announcements that come out each year, setting the standards for the program at every fiscal year. The agency upgraded and revised the regulations for that program in 2013, and we specifically took the speed tiers out because we wanted to basically have the flexibility as a broadband funding agency to be malleable and flexible to the specific unique speed needs of rural areas on a year-by-year basis. So we are mindful of the needs for high capacity throughput for rural hospitals and rural clinics to deliver digitized patient records and provide digitized patient care. And as a result of that, we try to set the speed tier for Community Connect at a speed level that is commensurate with the needs of the market in that in rural communities on average on a year-by-year basis. The broadband loan program, the minimum the total funding threshold for broadband service is a total of 5 megs, so you could do 4.1, and that's commensurate with FCC broadband standards. And the broadband speeds for the infrastructure loan program, I believe, are slightly less only because these are communities that are 5,000 or less. So these typically are very, very rural and remote communities, tribal areas, Alaska Native communities, communities in the Appalachian region, in the North Country, in the Delta region, really, really poor, underserved areas. So in sum, we do peg, by and large, the speed tiers based on the FCC's rules.
Thank you. At this point, we would like to thank everyone who submitted questions during today's webinars. Selected questions submitted during the webinar will be addressed by presenters following this event. The questions and responses will be posted on the HRSA website along with a recording of this webinar. I would like to thank everyone who attended today's webinar. We value your feedback and use it to plan upcoming webinars, so please take a moment to provide your feedback on today's event by completing the questionnaire that will appear on your screen shortly.
Ladies and gentlemen, the webinar has now concluded. We thank you for attending.